low school age, size differences. Yeah. I used to, I used to sideline doctor in football, and I never liked this. High school I didn't mind, middle school.
Morning.
Morning.
You're from the Department of Health, right?
Yeah.
Hi, I'm Jill.
It's already men.
Sorry.
Okay.
Yeah, I'm gonna try.
Okay. I don't even know what you're thinking about.
Congenital syphilis.
Oh, great. I think you're probably looking, unfortunately, about my
Oh,
infant.
probably, yes.
At Hillcroft. Yeah.
I wish I told them that they needed to invite the OB here.
No, they did that. They did it for them. They did it for them last week.
Good.
Here.
How are you doing?
Doing good. Better.
Oh, Robert.
Yeah.
I'm waiting for Kim. Judy's out, and I have no clue to PCI, but I'm going to try to help as best I can.
They're at 9:30.
How are you?
Oh, 8:30.
8 is their CME, 9:30 is their department meeting.
Right, so Kim will be here not till 9:30, you think?
Meeting this year.
Yeah.
Got it. Thank you so much.
Yeah.
All right.
Recording
Oh,
on a WebEx.
oh, good.
Yeah, so we say that. I'm gonna go next door and get you a cup of water, okay?
Thank you.
At least you have.
I came back from Asia. Playing back.
Oh yeah, that's how it rolls, right?
Or I'm not. The rest of me is fine.
I had something a couple weeks ago that was the same thing. Everybody's like, oh my God, you sound horrible. I'm like, yeah, I do sound horrible. I can't really breathe when I'm sitting, but otherwise I feel fine.
Yeah, it's like, you know. Yeah. Yeah, so talking will be a little hard. So.
Okay.
I'll try to do justice to what Linda and the other person did last time, but.
Which one do you want? The most recent one?
Yeah.
But I was as big as a fifth grader. You know, compared to a lot of the other.
I'm just throwing it right on the desktop so you can
Yep, great. That's
have your thing back.
And the WebEx
I'm gonna go
is
wash my
great for
hands.
other person. They can view that at any time.
I haven't pulled down and done the thing, but yes, they can. It's gonna be on the website that
Okay.
all the rest of their stuff is on, so.
Okay.
Oh, perfect, thank you.
I'll be right back. Oh no, I'm gonna step over there because I'll trip.
No problem. Yeah. Do you have any hot tea?
They appropriately
Yes.
learn how.
That would be like perfect, actually.
And like I said, I'm gonna bring some water over just.
Yeah, that'll help. I'm sorry about this.
Oh, no problem. I can't say. I can't give your kid testosterone because he's making it just a very small amount on his own. And like, he's not eligible for growth.
I feel bad for
And you know?
I mean, the estimated height is minus. I can feel so bad.
Which some people also get angry about. And
Right,
I'm
that's
just
right.
kind of like, I always tell you, marry taller next time, you know?
Yeah.
You know, so you go from these things as kids, you know, next time around.
Hey, how you doing? Right. Good, good.
This is what you've dealt in life, you know, you could be a very normal person and be on the, you know, below.
They might have their class. Really? You won't be class. I do have that. As I was coming in this morning, I'm like, oh no, we didn't do it. So I was talking to Barb.
Oh, Jill, I didn't mean to give you a hard time on that cardiology thing. So just give you the heads up on what happened last time when I almost got my head bit off by the department. I didn't even do it.
So yeah, so this one I think was going to be done.
Yeah, being done by a cardiologist.
Right, yeah, and
That was a commercial
for
thing.
people who's pre-positive or actually a visit with him there that day.
That's great.
And it's all free.
So
People who don't have, thank you.
Great.
Access to, you know, if you're for like uninsured, underinsured people.
Great.
You're able to have like a $5,000 deductible that you afford to pay towards that. They can show up and have like free screening, free EKG if they need it on the site echo and a visit with a pediatric cardiologist.
Great.
So.
That's exactly the opposite of what's happening. Sure.
So when you get here, if you could see the
Yeah.
that'd be great.
That's great.
If they're not here, just drop it back off now.
Okay, great.
But he said, he was like, that's my frustration with the types of screenings that don't involve the proper types of physicians.
Do you remember that one with the, oh, God.
Yeah, he was like, it's just kind of crazy.
It drove everybody insane, because 10% got screened as positive, and 2 of the kids, one had died and one got shot, and others got memorial. Because we're just hard to get over when we showed here, and some of the pediatricians going wild.
It's something they had planned. Those activities before the thing happened in New Paltz.
Yeah.
So,
What's going on?
like, unfortunately.
Not much. How are you? How are you doing? Good. Yeah, that'll bring a lot of people in.
It's interesting, I thought I would have more requests.
I had maybe 3 calls after that.
From what you said, because he was involved in that case, that it seemed like it was more, an electrical conduction disorder than it was, that's the thing, it was likely undiagnosed. And they're doing genetic testing for Gaucher syndrome because, the stuff itself, pathology, autopsy, it was of normal size and everything, so.
Worthy of publication. Worthy of publication. Something very exotic or?
Oh,
Probably
just that there was a
There was
sudden death of a
new
teenager, sports. Like, I don't remember that one. Or we didn't, right back, there was one girl who died, and then, which was bad enough, obviously, and then one of her good friends, classmate, softball teammate, and all that, dropped on the plane, and actually got shot and came back. So here was 2 girls in the same class. It was a very small class, about 100 or so. And what happened then was the parents arranged a type group to come in to do screening, EKGs and blood pressures and stuff. And they screened. What they did was they identified 10% as abnormal. Just sent the pediatricians a letter saying, "Is that right?" And the parents saying, "Your kid had a sudden death." Honestly, a cardiologist. So he flooded the cardiologist. They got pissed. All the pediatricians that got these letters got pissed, and they blamed me because it was my patient. So,
And they're thinking that it was a lot of QC and it just hadn't been diagnosed. Well, no, on review of the records, it seems that they have listed that their primary provider complaining of exercise.
What would you say?
Not necessarily, but
I do some practicing for my next career.
What is the instance of congenital whatever, next exercise? Must be very low, extremely low.
very low. I don't know a number for you at all. I know the last time that I went to.
But I do hear 1 or 2 cases every year.
Yeah. The last time that I went to a conference where they specifically addressed this, shortly after the kids that I had seen, I went to one, and, they did kind of the cost effectiveness of screening and all that. And, all of that keeps coming up with, it will do millions and millions and millions of dollars to find one. And you do better putting that in the school lunch program and not having heart attacks down the road. But the amount of just general screening, and then the trouble is, what they do is talk about screening the athletes and stuff like that, just as we talk about concussions and stuff, screening the kids who are varsity athletes. But other kids drop dead playing sports or something like that, or dance class or something else like that. So just screening athletes really doesn't be there. And so, when they've discussed the cost effectiveness part of it, it doesn't come up.
right, that's what I checked.
Very Yeah, because it doesn't necessarily have to be in a school team. Was this a school team thing?
I think it was probably sort of.
Yeah, so often it's not that. It's like a Little League player.
We see exercise with adolescents. Very good administration.
I've had people who tell me they're. I think it's the influence of allergies and the.
My husband was not happy about it.
There's some link to allergies.
Yeah. will only ever say shellfish, or celery, or wheat. There are two, and then if they eat it, and then there's another version that they eat anything where I was 6 hours covering. They do no food or no food. Two variants. Maybe a specific food. That's crazy.
The two variables will be present, and either alone will not do it.
Right.
And that's one of the reasons why if you ever give algae immunotherapy injections in your office, we tell them not to go to the gym for about an hour and a half.
Actually, we tell them to go to Europe.
There's like 183 foods that were associated with this dish.
Is that right? Wow.
Yeah. Although celery, shrimp, and wheat are like high.
Right. The recipe feels really good. It's there.
We can all be great in
I feel like the older I get, the more that I see, the less I know, and the more humble I become. It's like, oh my God, there's so much I don't care about it.
Yeah, okay.
She was a good friend, and I put her in. But you know, her tryptase level is a little elevated. Gastro, she likes gastro. Right, but
Email funding with backup yet? I don't know what that.
I think she's all I'm on.
And that's where I think the patient is
Even just to review it, by the way,
I've left them so back. But the other one had bone marrow here because they were really very I have one old guy,
actually, it's on your paycheck, should be.
Urologist, Trinity ORA, urgent. Any urologist, Trinity ORA, urgent.
Very little. I think it's been a cardiology. That's fine. I would probably. Yeah, that's right. 2 hours.
yeah. And my niece is already here. The other month I'm in a few patients. And I did a little. I
I even have like some basic. I'll be fine. I will. All right, good. People will translate into that type of.
Everybody, we all know Andy Rotan's from the health department. Andy is an honorary member of the Department of Pediatrics. I think he's attended more of our meetings than half the people. I'll just let you pick. All right, thank you.
No, not people here, people not.
Morning, everyone. So, at least once a year, at least I have to come and talk to you about some particular topic. So, the reason that I'm coming here to talk to you about congenital syphilis, I know you are in pediatrics. We've had 2 recent cases in the last couple of years that are of interest that you guys should know about. And we're going to be doing this kind of presentation to most providers in the county because we're trying to prevent the outcome of what happened with one of the bees. So it's just really, sorry. I just want to tell you, I came back from Asia just Friday of last week, and I got whatever the Hong Kong whatever, so like on the way back. So I feel fine, except that my speaking voice is not the best. There we go. So I'm just going to do an overview of what treponemes are. Go over what a typical syphilis presentation is, talk to you a little bit about congenital syphilis, talk about laboratory testing, treatment, the epidemiology of syphilis, to go over the 2 cases that occurred in Dutchess County recently, and to breeze over some recommendations based on those, what happened. Just so you know, I always put this slide in here, that as far as sexually transmitted diseases, what happens nationally is typically what's happening in Dutchess County. Whether it's syphilis, our trends parallel what is going on in the country. So if you want to look at the CDC STD website and look for national trends, you're more likely looking at what's going on in our own backyard as well. Okay, and this is William Osler, and I have this little green book here. When I first started this job, this is the first thing that they gave me to read, this little book on syphilis. It's still a timeless piece of information. If you could ever get a copy of this book, it pretty much tells you everything you wanted to know and was afraid to ask about it, except for maybe what the new is epidemiologically or what's happening with it right now, but nothing really has changed, except for maybe some of the treatment.
I know, right? Look at this size. Yes, let me know.
There are other treponemes other than the venereal syphilis. There's endemic syphilis, Jaws, and Pinta. Are not considered sexually transmitted, but they do come from close skin-to-skin contact. This is a distribution map of those other syphilis organisms. They tend to be in third world countries. That's as much as I'm going to say about those. Okay. This here is just your typical happens with syphilis. What happens is inoculation, usually the primary chancre, so someone has syphilis. Then it incubates about 14 to 21 days, and you get what we call primary syphilis. Then 3 to 8 weeks after the appearance of the chancre, you get to secondary syphilis, and after 3 to 8 weeks, the lesions disappear spontaneously. Then you go into latent syphilis for about 2 to 20 years. I will tell you with secondary syphilis, you can repeat bouts of secondary syphilis over time, all without treatment, and you could also get primary again later on in the infection. So it doesn't always follow this, But as far as epi-wise, you know, if somebody has a primary lesion, I can almost pinpoint to who probably exposed them. We have to have a way to do that. So I can tell that the person's lying to me, that like they didn't name somebody, because I can tell like the window where they were exposed to the disease. So primary syphilis, I know this is a good morning topic to have penises with lesions thrown at you this early in the morning. And I will tell you one thing, I find these pictures that they show on the internet and stuff are probably more the more typical ones. You know, they don't all look the same, and but just what we're doing is we're doing all this just to, you know, not a lot of you have seen syphilis. This is to remind you that it's there, and it should be considered a rule-out diagnosis if you're suspected. Okay? Again, it usually occurs 14 to 21 days after exposure, will disappear on its own without treatment, and can be confused with other ulcerative STDs. Very important. Most commonly, people often misdiagnose as herpes. A lot of these photos of people with these chancres and stuff are probably people co-infected with HIV, thus they seem worse. Yes?
I mean, herpes looks much different, I guess, but I've never seen syphilis. Can they look like herpes? I mean, are just people diagnosing it, or do they actually look vesicular little lesions like herpes?
Actually, the case fatality that we had,
Right.
That was the assessment of the primary lesion was herpes. So they can be coalesced lesions, but they're usually indirect, which is very different than herpes, which is usually elevated with, you know, fluid. But it should be, but it happens a lot.
And Linda Squires is in the audience with me, partly because I'm still not 100%, so I asked her to help me out a little bit as well. So, all right, again, you can also have multiple lesions as well, and probably this may be people thinking that it's herpes and not primary syphilis. Again, it can occur wherever the contact of the exposure occurred. This is one and near the anus, and the vulva, lung, on the finger. I mean, this is like one of those famous pictures that I've ever seen since I've been here. But, you know, people have sex or have sex in many different ways. And wherever that is exposed, there's a potential to get the lesion there. So just don't think, you know, dust in the genitals. Like secondary syphilis, the common symptom, and this occurs in both cases I'm going to talk to you, is a rash on the bottom of the hands, the bottom of the feet. There are very few diseases that cause that, or you can get a bilateral rash on the body as well.
I just have something real quick.
Sorry.
We see a rash like that every year, like cocktail.
Right, and I will tell you that, like the one rash, for the kids I'm going to go over, they did look into that. They thought it was Coxsackie virus.
That rash was seen by 3 different clinicians. Nobody thought syphilis. A woman had it, and then the baby died of hydrocephalus. But this is new. We haven't had genital syphilis for 25 years, it doesn't count. So this is new to everybody. So that's why we're making this effort. Can you go back to previous one again?
And CDC website, I think there's even modules that you guys could do on your own to review this as well. Okay. Training modules.
Are they painful lesions? Do they itch?
40% itch, but most of them are painless. And that's the other distinction with herpes. Often, you know, herpes is painful, but, you know, several clinicians have considered it to be herpes without any discomfort.
And do they fever when they have the rash? Just trying to think of clinical things.
In secondary, some people will have an organ involvement, particularly liver, and they get febrile during that time, but most people do not. Most people are given an ointment, and it's going to go away anyway. So they think that would be appropriate treatment, and that happens time and time again.
And that's one of the providers did. They told them that if the rash goes away, if the rash doesn't go away, go see a dermatologist. If persist.
It goes away all the time.
The other thing is like, to look on both and take their shoes off. It's very important. That doesn't often happen. Especially if you see it on the bottom of the hands, look at the bottom of the feet.
Primary lesion, yes, like the picture of the hand, but it's usually transmissible once the primary chancre is gone. With a few secondary exceptions, like the condyloma
Try to show them, yeah.
and mucus patches, which Andrew will show you, those are highly contagious.
This is mucus patches on the tongue. Those are highly contagious. There's treponines in there. This is alopecia. It causes a moth experience. Hair falls out in clumps. I will say that this only occurs in a very small percentage. It's very unusual. You can also get it in the eyebrows. They lose their eyebrows as well. This is the condyloma lata. This is also contagious. They may look like warts. Again, condyloma lata. Thankfully, we don't see a lot of this. This is really the end stage of the disease. Because of screening and hopefully getting people early, we get to this point. But late neurosyphilis, gummas of the skin, gummas in the organ tissue, aortic involvement, and death. And this is what the gummas are. They can affect virtually all parts of the body. Occurs 2 to 25 years after infection. I've never seen it happen within 2 years.
30 years ago, a lady with gummas all over her lip.
And though that looks horrible, they're usually painless and indolent. So, okay, clinically, cardiovascular syphilis, clinical apparent damages do not occur for about 20 plus years. Aortic, aneurysm, aortic insufficiency, osteostenosis, rare there, and electrocardiograph abnormalities. And I love this picture of the aortic involvement with syphilis.
Question.
Yeah.
With proper treatment, does that decrease the cardiovascular risk, or that is a risk regardless if you're properly treated?
If you're properly treated, you have the risk. It's curative.
Okay.
Neurosyphilis, 5 to 40 years after infection, 70 to 25. Tabes dycelis, paresis, dementia, and death. All right, let's get genital syphilis. Okay, early genital syphilis, acute findings from delivery, snuffles or nasal discharge. As you know, syphilis can be transmitted from the mother to the fetus through the placenta. And that's what's really important about this. But some of the early findings are snuffles, nasal discharge, and in that nasal discharge is actually treponines that cause syphilis. Primary chancre, bone involvement, anemia, pneumonia, hepatic involvement, failure to thrive. I wish I could speak better. These can occur within 3 to 7 weeks after delivery. Yes.
That's like bloody discharge. It's not always bloody though, right?
No, it can be just very euphoric, just like a friend.
Yeah. This is a primary chancre on the head of the back of the head baby. Conjunctival later manifestations, Hutchinson's disease or screwdriver teeth, Mullers, cracks in their nose, that's called Ragaz. Congenital syphilis that is persisted to 2 years of age. Hopefully we will not get to this point. I don't think. And this is the Hutchinson's disease. Late congenital syphilis, keratitis, neurosyphilis, eighth nerve deafness, vascular development, Clutton's joints. Again, this is the perforation of the hard palate from gummas in syphilis in a baby. That's right. This is that Ragaz I was talking about. Okay. I'm going through this fast, guys. I just want to get to the case thing. Just give you some exposure. I recommend that if you have the time to just go review this, just to have it, and maybe even take a module. So the treatment is dosage is based on stage of disease. If you ever have any questions, I'm going to say that here, we'll say about HIV or anything. If you have any questions about syphilis, give us a call. We work with syphilis all the time, and we'll help you. Okay, so if you have any questions about diagnosing, treatment, just we'll help you with it.
We also have 40 many years of records from the community of all positive blood, which would be extremely helpful if you get a positive blood.
Right. And treatment and dosage is based on the stage of disease. If it's early syphilis, it's 1 shot of bivalent. If it's a latent syphilis, we give the 3 shots. If it's neurosyphilis, it's IV therapy. It varies on stage, and we can help with staging because you need epi information for our investigation to figure out what stage the person is at, plus the records that one has. We also have records. We can go through the state. We can look in other parts of the country to see if, if a person has a history or not. The typical laboratory testing is the most common one is the RPR screening test, a rapid plasma reagent. The ART is almost never done anymore. I've not seen it anymore. The VDRL, that one is only done on cerebrospinal fluid. And the screening test is very sensitive, but it's not specific. So there can be false positives. And there are other things that can cause this test to be positive. We have a highly endemic Lyme disease area, another viral disease, and cross-react with this test. And pregnancy also can give false positive RPRs. They typically do it, and then we come up with a number value. The more intense the reaction, the more likely that it's an infection. And I've seen titers in the 8,000 range. So that's if a lab tech almost feels like going that far, to be honest with you. Once we're in the above the 1 to 16, we're in a good place as far as saying probably syphilis. I want to tell you when you're comparing, yes, go ahead.
Just explain that, those ratios.
What they do is like, in the first 12, you have 1 to 1, 1 to 1 to the test, and then you cut it in half, and then you cut it in half, and then you cut it in half, and then it keeps getting positive. Then you say that that's the number you get. And usually it gets to be, how good someone's eyes are. You see a little coagulation in the tail of it, because you spin it around and you look for a coagulation or in the tail.
What is what you consider positive, weak positive?
Positive is 1 to 1. That is considered positive.
Yes, confirmatory that you want to compare with this is a staging tool, whereas the other is a confirmatory tool.
Right. Thank you, Linda. And just want to tell you, it's very important. Comparing apples to apples and orange to orange is very important. Let's say you have a 1 to 1 and then you've got a 1 to 8, but it's 2 different labs or 2 different tests. You want to make sure you're comparing the same thing. So you have to get it repeated at the same lab, because again, this is an eyeball test as well. So, it's not an automated test. Okay. These treponema tests, the confirmatory tests, we have an IgG and they're called CIA or EIA testing. They're becoming the new wave. You're going to be seeing more of that happening. FTA, that is becoming less in favor, especially around here, because it definitely can cross-react with Borrelia burgdorferi. So probably would not recommend doing FTAs anymore if you can. Just not order them. The IJ, I've almost not seen that anymore. I think that evolved into the TPA if I read, and that's probably, if you're going to use confirmatory tests for syphilis, the TPPAs can discern Lyme from syphilis, and that's the one that's highly recommended. A couple years ago, the CDC put up new they haven't made it a firm recommendation yet because it's relatively new, but what we call reverse sequence algorithm. The typical algorithm is the RPR being done first, and then they confirm with a non-treponemal test, the TPA or other test, and if positive syphilis is likely, if it's negative syphilis is unlikely. What we now is the EIA and CIA, which is an automated test, and what that tells you is that someone may have been exposed to syphilis sometime in their life. So you still have to go back and do the RPR and the TPPA to confirm that EIA or CIA. and reverse sequencing is probably a really good way to go. You know, we're pushing towards that, and the CDC just hasn't enough of it to say that it's making a firm recommendation. But, you know, doing the EI or CIA can at least tell you that they may have been exposed to syphilis at some time in their life. You don't know if it's now or if it's 20 years ago. And again, that's how we can be involved. If you see that, we can help you with that. But then, like I said, the CDC has it on their webpage as well about the, yes.
Liza immune assay, it's IG screen. Or, it's an antibody, that's why it's so good, because the RPR is a bell curve. It's where you are in the infection. You can get a negative RPR on someone who has active syphilis. That's why they're really, you know, the industry is really starting to say they're faster, they're cheaper, and your hospital is working with, some of your administrations working with your lab to consider this modality in-house.
Anyway, I am really having trouble talking, sorry.
I think they ship it to Quest right now. For confirmatory.
Now we're still getting FTAs from here.
Yeah, and Dr. Weinberg came and spoke with your obstetrician and gynecologist last week. He's from the Center for Excellence, and I strongly recommend if you can tap into the recording. He was excellent. But it's an industry switch, so both things are going on at the same time. But the FDA in Dutchess County, the recent baby we had was treated with IV penicillin for 4 days until they could get the rescreening test back because the FDA was positive, but the TPPA was not. So the baby really wasn't infected. Mom had a history of Lyme. So that's why really encouraging people to get very familiar with the screening modality and the history that you take on treatment.
The news on that one, though, that everybody reacted quickly. They still started treating the baby anyway, like even though it was confirmed not to be syphilis. So.
But also the father later admitted to outside of the marriage. The mom,
yeah.
after that came back, she had to confront him.
That's, you know, that's the unit cost to an improper screening or, you know, misinterpretation can be extremely high. So they're not writing on interpretation.
Right, so some of the epi, and we'll get to the cases. Again, thank you, Linda. I'm like having such trouble talking. As like syphilis was really like a huge problem in the 40s and 50s, and we saw records from back actually of people who had syphilis. It dipped down when I started working in '86, in the '86 to '91. That was when it was in a heterosexual population, dealing with prostitution and drugs. And we saw a lot of congenital syphilis at that time because more women had early syphilis. And then it went down, and I will tell you in about 1998, we had zero new cases of syphilis in the county or near that. So that was really, we were actually talking nationally about syphilis elimination. And as you know, it got into the men who have sex with man population, and now we've seen a huge increase in syphilis. Rates reported in United States and outlying areas. District of Columbia has the highest rates. Wyoming has the lowest. Females in western states, I actually read about that we're seeing an increase, and also seeing an increase in congenital syphilis out that way. So when you start seeing the rate increase in females, congenital syphilis will soon follow. The state has 7.5 cases per 100,000 people. State map, and like I said, the male rate as opposed to the female rate is what is important here, and is that like for men it was 14.8 cases per 100,000. For women it was point per 1,000. So New York State, for New York, we're actually higher than the national rate. Okay. And again, men are most effective at syphilis. I want to keep hammering that home because I'm going to talk about congenital syphilis, but this is what's keeping it going. And like when HIV started, diseases don't care what sex you are or what kind of, whether you're gay, straight, or whatever. If you have sex with a person, they can get syphilis. But again, put that one woman down there, we can't forget about women with disease because the outcome can be horrible, as I can show you.
Candy, with the Dutchess County numbers there, you showed up in red. Does that reflect the general population? I remember back with TB, when Dutchess County would show up as having a certain number of cases, it was really the prison population that was there. Is this general population?
The general population. This is not the prison population.
Okay.
It's definitely changed the dynamic. We're not seeing it. When I first started this job, it was in the prison because it had to do with prostitution and drug dealing and all that kind of stuff. Now it's in men who have sex with men. And not to say that there aren't some of them in prison, but they're not as many of them in prison, I guess is what I'm trying to say. I can just tell you, I've seen very little symptomatic syphilis in prison. It's definitely, and syphilis I see there is usually related to something from the past. I said, let's not forget the women. MSM are epidemiologically important to the continuing transmission of early syphilis. But sex of men include homosexual, bisexual, and down low men. So I show this picture to keep that in head, that there's two men in the picture, but there's also a woman in the picture. Down low means that they have sex with men, but they don't admit to it. And they may be with a woman. They may not even be heterosexual at all, but because of societal work, they just feel like that they need to do this so that they can function where they're at, whether it's family, religion, etc. County numbers I'm going to gloss over. It's basically, like I said, we've seen that increase over time of early syphilis. That's the blue. Again, in red, just to take out the later syphilis, as you see the increase in syphilis locally. Keeping poor Michelle really busy now.
And the congenital in the center there, those were all imported cases?
Yeah, and that's what I'm going to go over.
Foreign women, but the new ones are ours.
Yeah, so those ones in 2001 to 2004, those were definitely foreign from women who had no congenital, no prenatal care, showed up in the country. One of them was a stillbirth, if you remember that case. The first one we had was in 2007. There was a case where it was related to SM exposure. I actually worked that particular case. The woman had sex with a guy in New York City who was an MSM. So, and the last two cases, 2013, 2015, we don't know about the 2015 case, whether it's MSM related. My suspicion is somehow it is, but the 2013 one most definitely was. Okay. So the first one is 2013. It was a 19-year-old female. She had a termination of pregnancy in 2012. She discovered pregnancy when going to the hospital for unexplained bleeding. She had an X-ray, and the spinal column of the skull was shown in the X-ray. She was 22 weeks pregnant at the time. You guys are shaking your head. Sorry. So, in 12-13, she had her first prenatal visit. Her RPR was non-reactive. The patient continued prenatal visits with about every 3 weeks after that. On April 1st, 2013, the patient presented with a rash on the bottom of her hands and her feet. The doctor did not repeat the RPR because it was the previous negative. Diagnosis is not chickenpox. It told the patient it was a benign issue. Claimed no new sexual exposure since the last visit. She delivered a baby. Her maternal RPR was 1:32. Return FTA was reactive. Case was not called in, and I review that with you. If you have a case of early syphilis, it has to be phone reported to the health department when you have it. And if you treat someone for syphilis, you have to call the health department. The mother was also positive for group B strep. The mother was treated for early latent syphilis. the gestation age of 39 weeks. The birth weight 6 pounds 13 ounces. The RPR was 1 to 16. The SCA reactive. The use of VDRL was non-reactive, so there was no neurological involvement. The long bones were normal. No symptoms. Treatment initiated. It was group B strep positive. That was taken care of.
Question.
Yeah.
At time when the RPR was repeated on the mother, what was the reason?
When they deliver the baby, they usually do one a couple weeks before the estimated time of delivery, do an RPR screening, but because they didn't, but when they deliver a baby here, they do an RPR at birth on the mother, and that's why it was repeated. Epidemiology, the last sex was with a partner. The partner was reported as 11/15/2012. That's what she told us. Okay. She's a student at a college in New York City. Claims that she knew her partner having sex with men, but we were never able to locate this gentleman down in the city. Okay. So the good news is that baby did survive. It does because the mother. I will say one thing about if the mother has symptomatic syphilis and is not treated, it is more likely to transmit it to the baby. And the other key thing is the earlier you can find out and get mother treated, the less likely transmission is going to occur. To close the pregnancy, it's too late. The baby will still have to be treated anyway. In the 2015 case, it was a 20-year-old female, positive pregnancy test on June 17th. She had class B diabetes, hypothyroidism, ADHD, and planned on repeat RPR 32 to 37 weeks in pregnancy. 29, she reported to OB with a right and left vulvar ulcer, about 2 centimeters. Testing done for herpes, gonorrhea, and chlamydia. Patient started on Valtrex. All STD tests were negative. No syphilis serology was done at that time. Fourth, OP is an endocrinologist because, again, she was having issues with diabetes as well. To discuss medications. Had a rash in the bottom of both of her palms. Epidemiological investigation, patient noted the rash was on the bottom of her feet as well. She didn't tell the doctor that, but when I talked to her, she said she also had the rash on the bottom of her feet. She was instructed that the rash remained to seek out a dermatologist. They screened for pox virus at the time. In 2014, she had premature delivery. EDD was 122 to 15. The mother's labs 1 to 64, FTA reactive. Infectious disease provider noted the fading hyperpigmented macular lesion on the soles of her feet. So she still had a residue of the secondary rash at that time. She was treated for secondary syphilis. The baby had aortic narrowing, trouble breathing. She was sick on the abdomen, kidney formation. And the RPR was 1 to 4. The FTA was reactive. The baby started on ampicillin and cefotaxime, but changed to penicillin G IV. No spinal tap done, as the spine could not be palpated. The infant died 4 days later. Autopsy confirmed congenital syphilis as the cause of death. This is a little bit touch of the epidemiology of what we do. The blues are men. The one there, KD, is the original patient. That's the baby that she had. But this is the guy that she had sex with that she named to us, who was also positive for syphilis. And he had been in Connecticut. He had been in other counties. He went to Connecticut. He actually had primary syphilis. And someone like me was supposed to conduct an interview, but did not. This goes to show the quality of work that I need to do, because if I can find the sex partners of these people, we can test and treat it. That's why getting us involved early is really important in this particular issue, because we're not even just like preventing, spreading in an MSM, but actually it could reach a baby, and that's one of the goals here of my job, is to prevent a baby from dying from syphilis. It's completely preventable, and that's why we get involved.
We were so lucky, because look how many babies this guy fathered. Look at they were okay. All things were okay, just the timing was perfect.
The timing was perfect. He also was living with a girl who was in another county who had a syphilis. I think she was 20 years old. The person over there did not elicit any partners from her, like I said, and he was living with her. Again, we could have prevented this, and that's what's really sad about this. Okay. Causes for concern about these cases is there was a lack of telephone reporting in both cases. Diagnosis of symptomatic syphilis during pregnancy. She was seen most of the time. They were seen by numerous providers. They did not repeat RPR, but they did other STD testing. Providers' lack of experience with syphilis. That's partly why we're out here. Yes.
I mean, from a systemic point of view or system point of view, would it be better to, for the lab to contact you for every positive?
The lab does.
And then there would be no lack of reporting in that situation.
The lab and the provider both required. Because
I know it's just that you're going to be in the same situation you are now, where some people are not going to report it.
Yes, we will be. 9% of
Where if you go by, if you're able to react to what the lab tells you, then you can mitigate the syndrome.
yeah.
And that's how we got all of these cases that we're describing was from the lab report. But the physician who drew the blood and followed the baby had that suspicion, and it took another 72 hours to get that lab, and then another 24 to post it. So that's why we keep both. And then we're going to be calling you anyway to get all the details, because when we get the lab, because sometimes we don't even get a birthday, we don't get an address, location. The labs do not report thoroughly, and there is delay. So it really depends on you as well. Depends on both. And both are required by New York State law to report. Yeah.
That is just not intimidation.
I know. That you anyway, that's what.
And the other problem is, again, even though I showed it to you, there is an MSM epidemiology bias with syphilis. Probably our fault because we come up, and the CDC, MSM, but again, that one woman is just as important as those 7 MSM. And cases that were leaked outside the county border. The one thing about sex is people just don't have sex in Dutchess County. They go to other places. So, they travel. Recommendations, re-screen patients later in pregnancy, their sexual history of patients, partners, counseling about safe sex, this is probably stuff that you can all do. Distributors, use the Dutchess County Department of Health as a resource. Again, we do a lot with syphilis, so call us, we will help you. Training, and again, I left this paper for you, but there's an app of the CDC app that you can put on your phone as ST treatment guidelines you can actually have on your cell phone, an app, and how to put it on. It also has about sexual history taking and other things. But I'm going to leave this with you so you can have it on your phone. So you can carry like an actual copy of the treatment guidelines. You can always have it with you. So again, local court plus blood testing of public health law in 1989. Again, I don't know that they do cord bloods so much here as they do test the mother's blood at Vassar Oswald. I do know you do that. And this we've already discussed ad nauseum. And that's only because in these two particular cases we did not get a call. I mean, one did occur over the weekend, but there is somebody on call at that time. So, and my sorry. Yes.
I just want to ask about the timing and the process. So I go and I see a baby and mom was positive or had a positive RPR. One to whatever, it doesn't really matter. Okay. So what happened at that point? What's the testing of the mom? What's the testing of the baby? When?
The mom had a positive RPR somewhere else?
No, she had a positive RPR here.
All right, here.
Yeah. And we don't have records from him.
Well, I would say give us a call because we can see if he has records already or was treated or, you know, that could be.
Or
And
she might be in contact with someone we're working too that we've been looking for, that happens. But confirmatory is your next step. You want to get a TPPA, you want to get an IG, you know, use
So
your
how long does it take to get those tests back?
It is a few days. That's why that one baby was treated in 5
So,
days.
so that's what my question, so you have a positive RPR, you're waiting for confirmatory testing, should you treat that baby and mom on your way there? One shot of penicillin.
Yeah. It's always IV. For baby, it's IV. Okay, which is, and 10 days worth. It's a tough decision, but the longer you wait, the higher the probability of serious problems. But in RPR and pregnancy, you can get a cross-reactivity with baby's blood or the cord blood, and it's a difficult call.
Right, so the FTA, how long does that be?
I think that is just a few days.
it takes a couple days.
Right?
No, I have a positive RPR, and I'm waiting for confirmatory testing. The baby looks fine, mom looks fine. Do I wait for the confirmatory testing, or do I treat?
I think that what we need to know exactly how long it takes to get those results, because I'm kind of assuming, so I would like to be sure of that. If you could get them within 24 hours, you'd probably be okay. If it was several days, I'd be concerned. And I always would take the opportunity to consult with IV. But we're working with your colleagues in the obstetricians as well, because we are really hopeful that increased screening in their practices, that the probability that you'll have to deal with it will become more and more.
I can tell you here what's happened is they say, well, we talk to people, so wait for the confirmatory, we'll see what that is. By the time they're negative.
Pregnancy itself can be a FTA.
I would say one of the things too is I would say consult us as well because we may have other information that you don't have, like Lynn was saying. I think that's the other part because there's symptomology and there's the epidemiology. And
I just remembered there's a new physician at the State Health Department, Debbie Vasquez, and she's been excellent as a consultant, and we can hook you up with conversation as well if you have a patient.
So with 95% of these, or 90% of these RPRs are going to be negative, I don't think we're going to call you until we get that confirmatory.
I would not suggest that, because the second you're even suspecting, we start helping you investigate the parameters of that case. We can help you. We can help you. And we get that positive RPR anyway. We're going to get that reported to us, probably not as quickly as
By the time you get that, you'll also have a confirmatory data that you won't be angry at us for premature.
So TPPA, right, it's not FTA.
But by law, you're responsible. And when we work with these families, we have the expertise to make sure that they truly understand that they're not saying you have syphilis. We're investigating that possibility.
So are we required to report every RPR or every positive syphilis? An RPR may not be a positive test for syphilis unless it's confirmed.
It is until it's ruled out. It is until it's ruled out.
We don't want to know that the lab doesn't know.
Yeah, it is until it's ruled out. It's a positive syphilis test until we can assure otherwise. And we have to follow it as such.
Linda?
How are you?
So I think Vassar here is in the process to implement the reverse testing.
You were talking about that a little bit.
With CDC. So, I'm not quite sure exactly when it was rolled out, but it was discussed. There's no objections to it, so the EIA is gonna go first.
That will help you.
because with the positive EI, that'll give you the idea that, like, it's most likely syphilis. So when you say the report, we're thinking that we're just going to do staging after that kind of thing.
Well, you're still going to get false positives with the reverse screening modality, but you're going to miss like you do with the old screening modality.
Right.
And you get that result faster than you do in all.
I think we're going to run it in.
And more accurately because it's not subjective.
like if you get a negative, you have to run the RPR.
No, we positive.
Stop after negative.
Go back to that.
Yeah.
That's the first line, you only,
Stop after negative EIA.
Shoot. Sorry.
The side, where the little pictures are.
Okay, you're right.
back in. Oh,
I'm having trouble with this thing.
right, so it's not there if it's negative. Right.
So negative.
You can have confidence in that negative test. I mean, it's not 100%, but it's significantly better than PCR. Right. And with all these tests, there's still that incubation window similar to an HIV screen, where that person, and that was the case with one of those girls, is that when she presented, she probably got infected 2 weeks before, or even after pregnancy, and yet the RPR was still negative.
There are less false positives on the EIA.
No, there are not less. It's limited, but it's not as specific.
Is there critical mass for the number of partners one has? You know, that more than 4 partners are likely to get GC, or more than 8 partners.
We have people who have 50 partners and never get anything, and then we have, it's more risky to have one partner that's your steady that's infected than to have 10 that aren't. Can't put that one. Everybody's a suspect.
Hey, Linda, sorry. I have trouble talking. Always have a checker.
They always
do.
always, but most of the time you can't see them, particularly in a female. They'll be internal, they could be in the back of the pharynx. For an MSM, they're going to be in the rectum. You know, a lot of times they're there and you don't see them. And
And even the ones that men will see on their penis, they might, like I said, I showed you those like huge things, but they're not always that big. They might be small, and they might think it's a zipper next to them or whatever.
That was the infamous thing when we went through this in the 80s and 90s. The guys would come in, I have a zipper cut, can you check? They all think it's a zipper cut.
How about secondary? Do they all get a rash? What's the incidence of the rash in secondary?
The rash is the most prominent symptom if you get them, but you can, like, and it's so interesting how similar it is to Lyme.
Yeah.
Who's in the same family. You can get the full presentation of each stage, where you can be totally asymptomatic. The spectrum is, that's why they call it the great imitator, because the spectrum is so broad of what presentation you might see.
With the congenital syphilis, when you have that spreads it.
Yes, it's contagious.
Teeming, absolutely teeming with virus. And have been cases of outbreaks related to that in nurseries. Thankfully, we don't, I shouldn't say it, must say it. Thank you all.
Thanks.
Thank you.
Thank you.
Sure.
And I'll leave you.
I could bring up similar issues with other hospitals.
Yeah, me too.
Yeah, if you want to, you can.
Well, while we're all done with this, do people need a minute, or should we just move on? I have a ton of stuff. I have some pals. Freddie, here's yours.
Oh, this was. Oh, I see.
And a bunch of them from Old Mid-Hudson.
Oh, I can bring it.
Okay, Old Mid-Hudson. I think those are all old. Just double check those as well. Herschel, why don't you go ahead then? Well, let me do my entire agenda. We don't have to do that. We got out of doing the, what do you call that, Mark? You did it, the dragon training. They wanted us all to come in to do the dragon training. I emailed them and said that none of us are going to be needing to do it. We'll all forget it before they change it the next time. And so we've been exempted from that. So we won't have to do that. So that's literally my entire agenda right now, other than things I'm going to bring up afterwards that are specifically related to the department. Yeah, Mark, do you want to comment on it, just because you did that training, just let us know what it was like?
So I did the training, it's basically using Dragon to do your note. There's a speech recognition program, and it does more than that. It allows you to say, place template here, things like that. There's a lot of commands. So it's something you need to learn. I think for some people it might be very good. If you're already dictating notes, it's great. For what we do, I'm not so sure it's going to be helpful at all. And even the guy who did it agreed. And I mean, it was worth my time doing it, but it was just to see what Dragon does. I'm not so sure I'll use it at all. But the one thing when ICD-10 comes, our templates will certainly have to be changed for appropriate diagnoses and things like that. So I think that's a big deal or not, to be honest. I don't think that it is because we don't have those diagnoses embedded in our templates. So you'll just have to change your favorite to appropriate ICD-10 codes. And I don't know how hospital's going to require people to use it. That may have.
What would be your reasoning behind requiring?
I mean,
I think generalizing with all the rest of the place. There's been one that I've done recently in the medical executive committee in terms of, for example, getting the privileges for the nursery that we have to do the 12 babies like I talked about the last particular time. I've downplayed how, I don't know if it's a good position to take or not, but downplayed how much involvement we actually have to have compared to many of the other people who admit here. It gets us out of this, but it probably takes away a little bit of what clout we ever had. But, it kind of says, we just come to the nursery and see these well babies right now, and so that's that. But, so it's gotten us out of this, it's gotten so that we can get we don't have to do all of the, toward inpatients, we can just do the newborns, but, hopefully not playing the card wrong anyway.
I mean, not any of us does do this, but we can wanted to, to the emergency room and do sepsis workup or see a patient that we've been following in the office, and now we want to go them in the emergency room as well. Is there a problem with any of that, especially for the new doctors?
I don't know. Once they're if they've come and registered in the emergency room now, we don't see them then. They are now patients of the emergency room, and if they consult us, then that's it. I don't know if we can specifically send a patient there only seeing us. I haven't dealt with that in a while since this has happened. But I know once they're here and registered, they're your patient here. They are the patient of the ER.
Are you allowed to do stuff on them?
No, other than when you're consulted. I'm not sure at this point. Does anybody, I probably should be the one to know, but does anybody else know that? I was caught off guard a year ago when I found out that we can't just walk in and see those kids who registered in the ER.
Well, you could go dropping orders on anybody. You guys have a patient who's in the ED and you decide to log on from the office and bring orders.
Is that only if we've been consulted?
No, and but there's, gotta be more careful about that,
Yeah.
Acknowledge your followers, but you.
Yeah, okay. All right, so you wanted to bring up?
2 years, it's been a problem every single one of them, nothing's ever changed.
the ER's handling of children. And I just happened in the last few days to have 3 cases in a row that were just appalling. And I've called Kim, and I actually spoke to Dr. Tattlebaum in the hall. We have a new ER group that has replaced the group that replaced the last group that replaced the last group ad infinitum, okay? And none of them get any better. And just to recount the 3 cases, the first one was in Putnam, was a 4-year-old special needs kid with UTIs who came in sick and had a urinalysis with 7 white cells in it, was diagnosed with UTI and treated without a culture. The next one was a kid who stepped on a pin at a big abscess, and they tried to get the pin out. They couldn't. They just sent them home and said it's fine, the surgeon. And didn't bother to culture the abscess, just put them on Bactrim. My favorite was the one that happened yesterday. It was a 17-year-old, big hulking kid with asthmatic who came in with shortness of breath but wasn't wheezing. And they didn't find anything. They did a chest X-ray, of course. And then the wisely prescribed Hycodan for his cough and prescribed Zopran in case he vomits from the Hycodan.
Oh, wow.
Okay. So it's just appalling. And for decades, they'll do a CAT scan on anything that breathes for any reason, but a culture is verboten. It's too expensive and not medically indicated. And I am just sick and tired of that attitude. If it's the protocol, it's wrong. I'm going to write Dr. Tattlebaum about these 3 patients. I would urge all of you.
Before he retired, would be fine.
In June, but he's the only one around now, so he's the one you have to talk to.
He's going to be retired June 1st, right?
I know that, but he's the only one you talk to, so, and actually I've known him for 30 years, and I think he'd actually follow up on it. I have no idea who, whatever, real administrator they're gonna hire after this won't. So, I would urge you to do that. Personally, I would like to see a departmental resolution saying that their lack of culturing of children or prescribing antibiotics is below the standard of care, and that we need to sit down with them as a department and go over their protocols for children. If they choose to do that for adults, go ahead. We don't care. That's internal medicine problem. Going through the QI committee has never worked. They've always said, no, that's our protocol. We're right. And it's a waste of time. So if you put a departmental resolution in public saying that you find their care substandard, that will get someone's attention because it can be used. So I think I can try to get something going with Tattlebaum first, but if nothing happens, like it hasn't happened in the last 30-plus years, I think it's time to make a very clear statement that this is not tolerable and we're not going to tolerate it anymore.
So Herschel, I'll nominate you to write the resolution and bring it to the meeting next month, and we'll vote on it. I don't think we'll have anybody, it'll be a unanimous vote.
But if anybody has more cases, it would be helpful with names and dates, okay? And I don't know, like I said, I've had 3 in the last week. I suppose if one looks for them, we can find them. I mean, I could ask you, Andy, I mean, ER docs have always told me, says, oh, no, you don't need a culture for an abscess. Drainage is curative. That's bull. Okay, that's what they've said all these years. And, you know, they diagnose adults with symptoms on the basis of white cells. I think that's also crap, but it's certainly bad for children. And if those are their protocols, then they're wrong. If they're just individual docs not knowing their medicine, then they need to be educated. So I don't know if there's anything in the ER literature that says anything like that.
Herschel, I can say in the adult ID literature, I actually went to an adult ID conference a few years ago just to see what they did differently. We're so better. Or so much more meticulous. But one of the things that they actually presented were studies showing that it is fine to treat UTIs by symptoms over the phone. Getting a culture would never make any significant difference in an afebrile UTIs in adults that you could call in Cipro on them. I was blown away, but this was what they actually presented on that. So
good for them. Continue the horrific wasteland of adult medicine.
Oh, I was shocked at how their ID is just so much less ridiculous than ours, their whole approach.
I mean, they're more meticulous.
No, oh my
But
God.
isn't that true across the board?
Oh, yeah.
They're more meticulous.
I was shocked, I mean, I was really shocked at this whole thing.
What do you do if you get an adult who has dysuria, and, you know, what else, whatever, and you get a culture, and you start treatment. Now she gets better, and 90% of the time or more, she's gonna have a negative culture.
I'm only quoting them. I'm not defending them.
That's the point.
They were saying without a culture, they said, they were presenting data and studies showing that you would get absolutely no significant gain by bringing them in and culturing them. You could treat them over the phone with Cipro. So that was literally, that was a
Negative culture.
What's that?
You know, that's gonna fly
That was
much longer anymore.
5 years ago.
Yeah, I mean, CMS is coming around, they're gonna collect all of our sepsis data.
Yeah.
And not getting culture is gonna be a huge, huge problem. So the ER, I mean, before this meeting, I came from another meeting that, you know, this is all about sepsis protocol now here. And so this not getting culture, it can't exist, because we're not gonna get paid. And of course, once you say that, it's gonna happen.
Well, I think Herschel's resolution, I think, will be very good.
So you said, I mean, whatever you just said.
Well, you know, I think the urine culture is different, right? I mean, urine culture is not part of the thing that they're collecting for collecting the blood culture, the urine, the data, and all that. These are being done.
In the sepsis protocol,
In
yeah.
the sepsis protocol, if the antibiotic is given in a timely fashion, if the patients are being bolus for their hypotensive shock and things like that, if the sepsis protocol is used. So, you know, some of it will get fixed because they are mandated, because, you know, in general, it's the sense has always been this, is that, you know, you need to improve quality of care, and this knowledge base there for pediatric patients, period. And you can have all sorts of algorithms, but, you know, knowledge is not there. You're letting somebody who has 100 contact hours in pediatrics manage kids. It's never going to get better.
Well, that's the question that I have overall. I don't know your knowledge, but not just here, but globally, because it's like, you know, Herschel said, I mean, and I have, you know, whatever, a third of his medical experience, but it's getting worse and worse and worse. I feel like the clinical care that patients are getting when they come to the emergency room, but yet the trend is that despite all the protocols that we have that we're supposed to be trying to keep them out, we're not. You know, they're going because everyone else out there says, no, you have a problem, just come, we're here, we're always here, just come see us. You know, don't wait and see the person who has that many more times education repeat. So is there a solution?
Jen, I met with the new group that's in the ER and addressed that to a certain degree about the whole issue with the PAs, when she's talking about the 100 hours of experience. That's all the PAs and family practitioners need. I think I brought it up at this meeting before, but not...
People talk to you and not assume that they know because they...
Yeah, well, I actually had a nurse practitioner student with me, a family practitioner, family practice nurse practitioner student with me recently. She said actually that she had gone to an urgent care, one of her assignments, she had gone to an urgent care where she was with a nurse practitioner who told her that pretty much any time that a kid, it's pretty convenient because anytime a kid has a fever, they almost always have an ear infection and they almost always need an antibiotic. So that's what she was being treated in her 100 hours of experience that she was going to have. When we brought this up with the new group here, the ratio of PAs to MDs in the ER, with the previous group that was in the ER, Jenny, wasn't it 2 PAs to 1 MD, and now I believe that's flipped the opposite direction.
So now shunted the PAs to the urgent care side.
Yeah, okay.
So they're not in the
core
much anymore. So, yeah, at least they kind of got that.
They showed the kids to the urgent care.
Yeah, I mean, not that kids don't get the urgent care side, they get free into that based on, what information is collected in triage, and they're assigned their severity and that according to FICO.
So here's my thought on that is, there's a part of my brain that says, maybe it's not the end of the world if that happens to be a PA, if they are sort of by rote following a protocol like that one, which is give them antibiotics regardless of what, but by protocol that says this is, step A, step B, step C, have such and so kid,
But Kim, as Jimmy said, if they don't understand and they don't have a basic knowledge of what they're doing, they're not going to get it. It's very hard for them to follow that.
Or they even know that the protocols exist and where to access them, because we've had protocols for a lot of my disease processes for over a year now, and people still are like, I don't know what to do. They're DKing here for 5 years and 5 hours, and we send nothing.
I just don't understand. We're electronic. Just Google it then. It's not.
I do that.
Isn't that what we do? We're not quite sure.
Oh, I do.
Just three points. First of all, I know many hospitals where there are pediatric hospitalists. When a child is under a certain age, it's an automatic consult to the pediatric hospitalist. I'm sure you want to do that.
You're not in a position to do
I'm
that.
just saying that they will not consult you, even though my main reason for sending them to ER is to get a real doctor to look at them. Right? But we have no way to do that.
You can request that any child is seen by a
You can request.
by an MD.
No, an MD, but by an MD that knows something about children. I'm not sure there are any there.
Yeah.
So
I don't know what the vetting
that's
process
number
is
one.
on that.
I don't think there is. But number two, our peace leader president has endorsed, the rational use of antibiotics is a national priority. This stuff can't stand if that's for real. Okay. And third is that the reason a lot of kids go to the ER is that too many docs sign out to the ER at 5 o'clock. They're signing out at 9 or 10, and that's better than signing out at 5 o'clock. So people go to the ER because that's what they're told to do a lot. So.
I also have a feeling that a lot of people, there are people who go, they're more likely to get antibiotics from them than from you. So that they could have even just seen you earlier that day or the day before, because you didn't, they're going just for that purpose. I don't want to wait the 5 minutes to get an appointment with you.
Does the ER staff have a medical meeting, CME program, so one of us could talk to them?
They do. Jenny has set up programs with them again and again and again. 0 people show up.
Yeah, that's the problem. See, my gripe is kids have with anaphylaxis, they get steroids and antihistamines, and EpiPen, and they're lucky they haven't lost anyone. So
that's been a difficulty. We met with them. We got a lot of happy talk from them when the new person was starting that there's going to be an improvement in all of this. Herschel's experience this week doesn't.
I got one that happened not at our hospital. It happened at New Milford Hospital. A kid comes in, gets an X-ray, shows some torus fracture somewhere in the upper arm. Seen by PA, gets put in the and said, this will heal. And follow up, no orthopedic. And now comes to me 7 weeks later for clearance to point. And I said, you can have clearance when you see an orthopedist and repeat the X-ray.
The opposite happens here. Every little twist of your toenail, they refer to orthopedics when you could just speak over.
So let me broaden this out in 2 different directions that I want to take the same discussion. One, a few months ago, we brought up the issue with Mid-Hudson Regional sending kids that could have been here down to Westchester. Before we fought with them, I wanted to see if people got more of those cases. It's a trend. I haven't had any more. I have 2 other issues then of other hospitals then as well that I'd like to bring up. One is, are we getting any feedback from the hospitals that we refer people to? I have had 2 cases in the last few weeks with Albany where I got 0 communication. Mark had an issue. Let me bring up the Albany one.
I sent a kid up there with Wilms tumor, brand case, sent up there. I just found an abdominal mass the kid was operated on within a few days. I saw the kid yesterday for the follow-up 3 weeks later. She's been home for 2 weeks right now. The mom and I had, we talked along the way, so I knew what was going on with the kid, and I spoke with the resident the next morning after. And when I sent the kid there, I thought it was a big spleen. And when the kid, I called and I spoke to a resident. She called me back the next morning saying, no, it was a kidney. It looks like Wilms tumor. And that was the last communication I got from anybody up there. I did finally get a document from them, which basically was the admission labs and one of those form things telling us that they informed the patient not to smoke. And it's a 2-year-old. And that was it. I got nothing at all. So I intend to discuss with them. I also had a kid that I sent up there, a kid who, just as a follow-up for here, and an interesting thing when we're talking about the antibiotics, a kid, very toxic kid with C. diff. Absolutely normal 4-year-old kid, has been on 7 or 3 times in the last 6 months. It's a mom who's always seeking antibiotics. I have caved for her in the past. But the time he was on, it was more than a month ago, came in, had probably that gastroenteritis that was going around, and then spiked to 104. This is a kid who came to the ER at Northern Dutchess, got a shot of Rocephin, got sent down here, but because the kid had a white count of 9,000, I think it was admitted here, had a count of 9,052 bands, kind of low blood pressure, and concern over significant sepsis, was sent up to Albany. Kid got better right away after that. Yes, this was just, yes, I'm telling you right now, yeah. So went up there to Albany where he got better and sent home kind of mocking. The mom said, they were like, there's nothing wrong with your kid, why are you here? And sent the kid home. Got Rocephin. I mean, this to me is interesting because the kid had C. diff. No stools after that at all. Playing around for 2 days, started getting a little sick. I saw the kid, a sore throat, did a strep test, it was negative. Came in a few days later, high fever, lots of diarrhea again. He'd had lots of diarrhea at the onset of that other particular thing. And then stopped immediately after that, 1 dose of Rocephin. Weird, I don't know. Came back in, no stools at all, playing around, and then spiked up to 103, 104 again. Came to the ER where they just sent him back up to Albany again after giving him a shot of Rocephin. And he got better again right away, and a second time in a row was sent back from Albany. Now, they never did a stool up there for anything. Came back in, no stools for 2 days.
Were any stools here?
He was here very briefly, and I don't know that he had stools here. I'm not sure that he had diarrhea here. He went out fast.
Rectal swab, for God's sake.
Yeah.
I mean,
anyway, but let me finish the story.
Should add that to the list.
Let me finish the story. And so basically, I saw the kid a couple days after discharge, again from Albany. I got no communication whatsoever from them. Sent the kid home saying, really, stop coming back here. Your kid's fine. Also, at that particular time, on that admission, I had a count of 30,000. And a CRP of 172. The kid, defervesced, looked fine, and went home. Came home, 2 no stools, running around, and started looking sick again. I got the C. diff. I gave him another shot of Rocephin. I thought it was maybe sepsis because he'd gotten better both times with the shots of Rocephin. This time he didn't get any better. White count was still 18,000. C. diff came back positive. Before it actually, when I sent him, when I saw him and sent it, I said, which am I going to treat? Am I going to go toward the salmonella? Am I going to go toward C. diff? I wasn't sure yet. I put him on Flagyl, and he got her in a day, and is perfectly fine right now. But kind of an instructive case of a very toxic kid, intermittently lots of diarrhea, got better with Rocephin, I don't know, toxic-looking labs. And it turned out to be C. diff and got better on C. diff treatment. But again, no communication. So I intend to talk to Albany about the lack of communication. I wonder if anybody else has that experience and the same experience with Westchester.
Westchester does not write notes except for a few departments unless you specifically call. Cardiology almost always writes notes. Endocrinology writes notes maybe half the time.
We're talking about the inpatient discharges.
But inpatient, outpatient, it's all the same problem. They don't view us as being worthy of communication. Now, I know a doctor in Philadelphia that has a series of 3 letters of all ilk who don't send their notes. The first one saying, please send this back, we refer you patients. The second letter, when they continue doing it, says that, we're a medical home, we're required to track this. When you don't do it, it causes us a lot of trouble. And the third one says, if you don't communicate, we're going to send our patients elsewhere. And it's a series.
My trouble now is the elsewheres are both not communicating.
Well, I would vote for Montefiore in New York City. They've been uniformly good about communicating. They've been very nice to people. You just got to get people to go there, which is a problem.
You're patient because I'm like, we're kind of appalling, so, those of us who are at the northern end of the pier are real limited.
Well, we're limited in Pauling too. There's only Westchester.
I shared this, but has anybody else had any different experiences? Has anybody been getting communication back or anything like that? I will say a year and a half ago, I met with all of the directors of the departments at Westchester. I went down there, and the hospitalist person said that they were really working on a system where they were going to, because I complained that you send a kid home, we see him 2 days later, we don't know anything about him. He said they were working on a system where they were going to guarantee us a discharge summary within a week. I said, it's not good enough within a week. By then, we've already seen the kid, and we don't know what's going on with him at that point. I'm still not even getting that discharge summary at this point. Does anybody have a different experience? Cesar, you had your...
The same thing that, I have a teenager with ulcerative colitis, has the and just partial colitis. I did not get anything from them, and the patient comes to follow up, and then you have to figure it was on the phone, but God knows how many phone calls we made to get some.
And yes, now they're like, no, they have to do medical records.
I thought Albany was a little bit better than Westchester, but now you have that.
I did too, and in the past, I've had people up there at Albany, and before they came home, I was called by a hospitalist maybe a year or two ago, but this time, again, I had a kid who was up there, a nephrectomy, coming on chemotherapy, not a word. Cesar was really...
The last time that I got a report from them, I don't know if that guy is like the attending for the week or the month. They have a hospitalist, that same guy called me, and this is two different occasions.
Okay, so you did get some
Give me a
communication.
report verbally before discharging.
Good.
To make plans. I send him back, to give us the discharge summary as well.
I had that, I have to say, I've had that maybe 6 months ago from Westchester, but where they called me to
This guy
tell me.
calls you before they discharge the patient and make plans for you.
Good.
Okay.
That's what I need to request. That was all you're saying?
Attending for the week, or?
And that was Albany or Westchester?
Yeah, Westchester.
Okay.
Spoken to the chairman of
Well, Mark, you were trying to contact Michael Witz.
So I sent him an email, he never responded.
All right,
But I think it really depends on the department. So two examples. One, I had a girl with ITP who I Westchester. I couldn't speak to anyone. Probably 40 minutes later, the fellow gets on. I say, I really want to talk to the attending. They won't get on. They're going to tell you the same thing. I call Albany. The attending on. I'll see them today or tomorrow. They were seen. They called me. They sent me stuff. We always had good communication. Another child, a 17-year-old girl with blast, very hemoglobin. I'm calling Westchester to try and reach someone to let them know. This is Friday after 5 o'clock. 40 minutes go by. I didn't get a page back. I didn't get a call back from the fellow or anybody. During 40 minutes, I'm trying to call the ER to let them know that this patient is coming. They put me on hold. Someone picks up, oh, you'll be on hold. I'll go get someone. Probably an hour on hold. No one picked up. Finally, I repaged and I spoke to the fellow, and I told the fellow, this patient's coming. I would like a call tonight. She says to me, the parents will be in contact with you. I say, no, I would like a call from you guys. Here's my cell phone. I want to know what's going on, what you guys think. Phone call. The next day I have to call again. I get a big stink. Finally, the attending calls me back much later to tell me what's going on. So I will not send another patient down to Westchester for hemo. Cardiology, totally different experience, okay? The ER, if I could avoid Westchester, and maybe Albany too, but I think the ER is a black hole. It's not necessary, I think it's very specialist dependent and department dependent. So,
I'm going to try to contact them, both of these, the chairman of both departments, and try to play one off the other.
Comment, David. Talk is cheap. paper is not. And it's the same thing. I was involved reviewing a med-mal case against Westchester, which they lost for an astronomical amount of money when they sent the kid with herpes home. He was referred in with herpes, an infant, okay? And he was really referred in for herpes and then sent home by their ER. Okay? And Chief, you can talk to Gowitz. Again, 30 years I've been talking to Gowitz. It gets you nowhere. If you actually have a formal statement from the department saying, we find the communications of the following departments entirely inadequate and it compromises the standard of care, woo, that's discoverable. Then all of a sudden they better do something or else that's going to be brought up in every malpractice case they ever face. So I don't know that you have to do that right away, but I think that's a very nice club to say, we're going to do that if you don't get something done. I'm tired of talking.
Nothing else for today.
I'm in the process of booking our speakers for next year. So if you have any ideas of people you'd like us to invite, all the input I got for you for this year, we invited the people. They were more than happy to come. So, any ideas, just email me, jbrodsky@nkmg.com.
Jill, did you want to talk about the cardiology screening?
I don't have the details on me right now, but this weekend on Saturday, Eric Fesky, who's a pediatric cardiologist in our region, he actually was a speaker here last year. He's working with an organization to do a cardiac screening day geared towards uninsured or underinsured or families that have very large co-pays and deductibles that might be hesitant to seek specialty care because of the cost to them, where he will be there personally supervising the screening of the children. And for kids screening positive, it will conclude with him there that day doing a visit with them and reviewing all the information and then arranging for him to follow them up as well for no cost to the family. I sent the flyer to Dave a couple of weeks ago. I think it out to everybody. I'm not sure, so check your email.
Yeah, I think Michelle sent it out.
Okay. So if you do have patients, they should call ahead of time to just let them know that they plan to come. And then, it's open to anybody who wants screening, high-quality screening.
Can you resend that? In terms of gloss over things coming from Michelle.
You could just search the deleted folder for Michelle Palumbo, and you'd be able to find it that way as well. I know because he's part of Orange Regional, so I know he had a very aggressive campaign on the other side of the river. So I'm not sure if it's made it to the schools on this side of the river. Again, it's at the Monroe Woodbury High School Museum.
Is he private or is he with a institution?
He's private, yep. He still has his own private practice. He has 2 partners. He comes to our building in Poughkeepsie 2 days a month. He also does most of our fetal-related stuff through Mount Kisco, Mid-Hudson. I think he's very smart. He provides high-quality care. He's an excellent communicator. And he really has an interest in cardiac genetics as well and congenital heart disease. So I think he's a great resource.
Does he have a Columbia connection?
He does.
Columbia,
Yep.
that's what I thought,
He used to be at Columbia.
Yeah, he was at Columbia, and then he decided...
He came to Middletown.
Right.
He's absolutely amazing, and the enthusiasm and today's intelligence, and has not lost his problem. Never say no to
Jenny, do you have anything you want to bring?
Yeah, I know I said this last month, but, when you call us for a direct admit, just make sure the parents understand that they are admitted. Last month, I mentioned this at the meeting, and within the week, we had an AMA. They came in and they walked. They were in, we did the whole HNT, putting the admitting orders. They're like, we weren't told we need to stay, the baby's fine now, and they left AMA. So we don't want to have to. So if you're calling a direct admission, and if there is always a possibility, if it's an early admission, it was for something that, could resolve for, they could get discharged. I'm not, have we done that? We did. But, they're here, and they should anticipate.
Great. Mary and Kim, do you guys have anything? Do we have charts that we need to do today? Okay. And Catherine, you sent me an email about
Sounds like,
of it.
you guys doing what you're doing.
Took care of it. Good, good.
The nursery committee is meeting and we're trying to make a lot of changes with our nurse. I'm working closely with, IT on that, so I'll have a smaller group right after this to discuss it.
Great, you have charts, so if people can go next door and.
Where is nursery being held?
Should we,
Nursery, Catherine, where are you gonna meet?
should
Meet right in here? I mean, you can, just stay in this room.
you still want us to tell the nurses each and every time that we don't get results copy and RER's not there, et cetera, right?
Like put a form there, a hassle form? Say, I was hassled because this wasn't in here, here's the baby, and then just file it with someone? And talk versus paper. It gets paid attention to, talk does not.
Filing a minus every day, and Wendy just told me she's filing minuses this morning. The head of our safety department asked me in a safety huddle we do every morning with the entire leadership team why it's getting repeated minuses about result copy not.
What's that,
Their report.
So,
It is on paper and it's trackable.
Okay.
Teresa, who's the director of labor and delivery, has rolled out change in the workflow that is intended to fix some of these things. It's not perfect yet. It's going to take some time, but that's what she's hoping is going to help get us to where we need to be.
Why don't we break up into those committees?
Michelle, I was able to give out all of those, the ones that were missing.
Oh, fantastic.
I gave that to you 4 years ago.